السلام عليكم. اهلا وسهلا بحضراتكم، اهلا وسهلا بكم في ويبينار جديد، ويمكن هو ويبينار جميل، ويمكن هو كمان ويبينار مختلف. يمكن احنا بنهتم جامد جدا مش بالكلينيكال ميديسين فقط، برضه بالبيزك ميديسين اللي هو لا يقل اهميه عن الكلينيكال ميديسين. ان شاء الله النهارده هنتكلم عن الهيستوباثولوجي اوف دايابيتيك نيفروباثي. وطبعا يشرفنا يكون معانا الدكتوره ساره حسن توفيق، اسوشيال بروفيسور اوف باثولوجي and director of microscopy and the head of electron microscopy department تدور بالهارس ريسيرش انستيتيوت. يمكن دي تاني مره يبقى في تعاون بيننا وبين ريسيرش انستيتيوت اوف تيدور بالهارس. كان لينا شرف ان احنا نظمنا كورس قبل كده مع تيدور بالهارس. الكورس كان جميل جدا، كان اي سي يو نيوتريشن. البيزك ميديسين مهم جدا ولا يقل اهميه زي ما قلت عن الكلينيكال ميديسين. الباثولوجي من العلوم الجميله جدا وسهله جدا. يمكن احنا كنا اتكلمنا قبل كده عن الفارماكولوجي وقلنا ان هو من العلوم الصعبه شويه ومهمه جدا. الباثولوجي من العلوم اللي فعلا مهمه جدا ومرتبطه ارتباط غير عادي بالكلينيكال، في نفس الوقت من التخصصات الجميله جدا يعني اللي معظم الطلبه كانوا بيحبوها، وهي براكتيكال جدا ومهمه جدا في الكارير. وبرضه اعرفكم بنفسي، انا دكتوره مش شابيني، سوشيال بروفيسور اوبيداتيك اناتولوجي عند كورسانتا اوبيداتيك كلينيكال نيوتريشن. اهلا وسهلا بحضرتك دكتوره ساره، نورتينا في الويبينار الجديد. موضوع جميل وموضوع مختلف، وان شاء الله تبقى محاضره جميله ويستفيد منها الجميع. اهلا وسهلا بحضرتك، اتفضل.
اهلا بحضرتك دكتور رامي. اي هوب انها تكون سهله فعلا زي ما حضرتك بتقول، ان شاء الله تبقى سهله. ويا ريت لو في اسئله في النص حضرتك تبلغني بيها، لو جه لحضرتك اي اسئله من حد من الاتنديز علشان يبقى الموضوع واضح، ما يبقاش في الاخر في حاجه يعني اتبنت على معلومه مش واضحه يعني.
هو بصي حضرتك، احنا دايما بنقفل الشات وبنفتحه في الاخر عشان ما يحصلش تداخل في الاصوات. واي سؤال everyone is free to ask في الشات او فيربلي مع حضرتك. اتفضلي حضرتك.
احنا ممكن نعمل ستوب في النص لو حابين يعني، وحد حابب يسأل حاجة.
مفيش اي مشكلة.
احب يعني اشوف الناس متابعة ولا. طيب بسم الله الرحمن الرحيم. هو الدايابيتك نفروباثي يعتبر مايكروفاسكولار كومبليكيشن الدايابيتس ميليتس. البروجريشن بتاعه بيبقى الاول مايكرو البومينوريا، بعد كده بيبقى بروتينوريا. تقريبا بيبقى بعد ديكيد من الستارت اوف دايابيتس. طيب يعني اي واحد دايابيتك، احنا هنا بنتكلم على النفروباثولوجي اللي هو العيان بيتاخد له رينال كور بايوبسي which is an invasive intervention ليها complications كتيرة. اي نفرولوجيست بيفكر كتير قبل ما يعملها. فاكيد الدايابيتس اللي الكورس بتاعه معروف انه هيعمل مايكرو البومينوريا مش هيبقى الفيرست تشويس للعيان ده ان احنا ناخد له كور بايوبسي. في التيبيكال كورس اوف دايابيتس usually renal biopsy is not done. امال امتى بنشوف البيوبسيز اللي احنا هنشرحها هنا ونقول الديفرنشال دايجنوزيس بتاعها؟ لازم يكون الكورس atypical، يكون في حاجة غريبة خلت النفرولوجيست يقرر ان هو ياخد بايوبسي. atypical course يعني في ليجن تاني او حاجة سوبر امبوزد ليجن موجودة، مش مجرد دايابيتس، ويكون الكلينيشن شاكك في وجودها فيخليه ياخد البيوبسي. هنشرح اللايت مايكروسكوبيك بيكتشر بتاعة الدايابيتس تحت اللايت مايكروسكوب. احنا الباثولوجيست طبعا عارفين ان احنا في النفروباثولوجي عندنا 3 modalities for diagnosis. 3 حاجات complementary to each other اللي هو اللايت مايكروسكوبيك examination والimmunohistochemistry او immunofluorescence والالكترون مايكروسكوبي. فاحنا هنشرح الباثولوجي بتاع الدايابيتس بقول these modalities عشان نوصل للديفرنشال دايجنوزس، لانه الديفرنشال دايجنوزس بتاع الدايابيتس اهم من هو نفسه علشان اغلبها حاجات كريتيكال، وبيبقى الهدف من البيوبسي اصلا ان احنا نكسكلود الاذر ليجنز. فالجلوميرولار تشينجز بتكون glomerular basement membrane thickening, mesangial expansion أو nodular glomerulosclerosis. mesangial expansion عندنا مشكلة في السلايدز مش عايز تتحرك.
ممكن حضرتك تخرجي من
غالبا
حضرتك تخرجي من السلايد شو وتدخلي تاني.
اوكي. الميسنجر اكسبانشن ده is of variable degrees، يعني ممكن يبقى mild، ممكن يكون moderate، ممكن يكون severe، وممكن يعمل نوديولز اللي هم اسمهم الكيملشتاين ويلسون نوديولز، وبيكونوا بيتميزوا بان هم نون ايزومتريك نوديولز يعني مش قد بعض. طب نشوف قبل ما نشوف الصور. upon chronicity بعد مدة بيقلب بجلوميرولوسكليروزس وإفتا أو interstitial fibrosis and tubular atrophy which is the end stage of all renal biopsy pathologies يعني. فده شكل الميسنجيال اكسبانشن اللي هو بالاستريكس باين، والممبرين هنا thick اللي هو بالشورت thick arrow، والبومن كبسول كمان بيبقى thickened زي ما باين في الصورة دي. زي ما قلنا التوبولار بيزمنت ممبرين كمان ممكن يبقى thickened، ودولت النوديولز اللي احنا بنقول عليهم اللي هي الكيملشتاين ويلسون نوديولز، وهم دول مش ايزومتريك مش قد بعض، دي كبيرة شوية دي اصغر شوية دي اصغر شوية، والاهم ما يميزهم هي الجملة دي باس ستين بوزيتيف اللي هي البريودك اسيد شيفت ستين بوزيتيف. سو diabetic nodular glomerulosclerosis are باس positive. في حاجات تانية باثولوجيز تانية بتتذكر دايما اللي هي الكابسولار دروب وحاجة اسمها الهايلاين كابس، دول not that common ان احنا نلاقيهم، بيكونوا more characteristic. upon chronicity الجلوميرولوسكليروزس بيحصل ان interstitial fibrosis and tubular atrophy. so كل الجلوميرولاي اللي قصادنا دول ايه؟ دول sclerosed، والtubules are atrophic or with variable degrees of atrophy، وin between interstitial fibrosis starts to appear. الفاسكولار تشينجز الحقيقه انه احنا قلنا اصلا هي فاسكولار كومبليكيشن، فالفاسكولار تشينجز في الدايابيتس are characteristic by hyalinosis. بس الهايلينوزس characteristic of في الدايابيتس هو ايه؟ ان both الافرنت and efferent arterioles will become hyalinozed، مش زي الهايبرتنشن. الهايبرتنشن هيعمل برضو سكليروزس بس بيعمل في الافرنت arterioles only. هنا في الصورة ديت الناحية اليمين هنلاقي ان الارتريول اللي داخل هنا ده مش هايلينوز، ده النورمال، عشان نكمبير بصورة مبينة afferent and efferent arterioles الاثنين، والاثنين are hyalinozed، فده characteristic للدايابيتس. وفي نفس الصورة هنقدر نشوف الميسنجر expansion with the evolving Kimmelstein-Wilson syndrome which are as we have said باس بوزيتيف. نقدر نقارن هنا ما بين الميسنجم، هنا احنا مش شايفين هنا ميسنجم، شايفين الكابيلاريز، الميسنجم مش باين لانه النورمال ميسنجم is inconspicuous يعني ما يبقاش ظاهر، لكن هنا الميسنجم بقى conspicuous واكسباندد، ثم عمل كمان الكيملشتاين ويلسون نوديولز اللي هم الباس بوزيتيف. طيب الاميونوفلوريسنس او الاميونوهيستوكيمستري، الدايابيتس is a non-immune complex mediated disease، يعني مش المفروض ان هو يكون فيه immune deposits، ده just glomerular hyperfiltration overload على glomeruli، فبتسبب ايه؟ بتسبب انه more plasma proteins will pass through the glomerular capillaries and cause some entrapment of these proteins. So we'll find some linear deposits of IgG, of immunoglobulin G, because it's just a plasma protein, so it will be entrapped together with albumin along the glomerular basement membrane, but without complement deposits, without C3 deposits or another immune complex immunoglobulin deposit which is IgA. Just an IgG will appear to give this linear non-specific, so it's a non-immune complex mediated disease, and this is a very important issue to put in mind when we are differentiating between diabetic glomerulosclerosis or diabetic nephropathy from from its differential diagnoses that will be discussed later on. So we mentioned the BAS positivity of mesangium, and here the IgG positivity that could be seen in immunofluorescence or immunohistochemistry without complement activation, no C3, because it's a non-immune complex mediated disease. In electron microscopy, we will find diffuse thickening of the glomerular basement membrane, increase in mesangium. Food processes of the podocytes will be effaced without electron-dense deposits, without electron-dense immune complex deposits. We should put in mind in some cases, and it's not an uncommon scenario to find non-specific changes under light microscope. You cannot see a prominent increase in the glomerular basement membrane thickening, but it is seen under electron microscope with thickening of the glomerular basement membrane. And by the way, the thickness of the glomerular basement membrane should be compared, or should have a control for the patient's age and sex. So if every age group has a range of normal glomerular basement membrane thickening, with the child age group up to 10 years and more than 10 years is considered as an adult range of glomerular basement membrane thickness. And women are different from men, so sometimes the patient is do not know that he's diabetic, and they discovered that he's diabetic from the hemoglobin A1C laboratory investigation. And under the light microscope, the electron microscope, this thickening of the glomerular basement membrane could be the first hint, unfortunately, after the renal biopsy for an indication of albuminuria for unknown cause. And the patient proved to be at last just diabetic, and he do not know, and was not properly investigated prior to the decision of renal biopsy. So this two electron microscopic pictures comparing between the thick glomerular basement membrane of diabetic nephropathy when we compare it to the normal thickness down here. But it's a diffuse thickening and homogeneous without changes in the consistency of the glomerular basement membrane. And that's very important, because one of the differential diagnoses is Albert syndrome that can cause thickening of the glomerular basement membrane, but totally different clinical scenario with hematuria and maybe some systemic affection, another clinical scenario. And with changes also in the consistency of the glomerular basement membrane with lamellation and other picture that may be discussed later on. But just now put in mind that the glomerular basement membrane is just thickened and homogeneous like that, with the podocytes here are diffusely effaced, while here the podocytes are normal. That's the mesangium matrix, which is expanded here. Okay, let's start the differential diagnosis. First, the hypertensive nephrosclerosis with the arteriosclerosis and elastosis in the arteries, and in the arterioles we'll find hyalinosis, and as we mentioned, it will be mainly in the afferent arterioles. So let's see this light microscopic picture for an artery. Actually, this is an artery and this is an endothelium, and that's the elastic lamina that, as we can appreciate here, there's multiple layers from this elastic lamina. 1, 2, 3. That's what we call elastosis that occurs in hypertensive patients. So that's one of the clues of hypertensive nephrosclerosis. The glomeruli will be ischemic and shrunken with periglomerular fibrosis, no nodular glomerulosclerosis. The glomerular basement membrane could be thickened as well and wrinkled, but less prominent than diabetic nephropathy. Let's compare between this picture that we have seen for diabetic nephrosclerosis or diabetic nodular glomerulosclerosis with the mesangial expansion and thick membrane versus the hypertensive affection of of the hypertensive affection of this glomerulus, with the periglomerular fibrosis, with the small shrinking glomerulus and the slightly thickened glomerular basement membrane. Another shrinking glomeruli with periglomerular fibrosis. The second differential diagnosis is one of the important differential diagnoses is amyloidosis. The main difference between diabetic nephrosclerosis and amyloidosis under light microscope is the BAS stain, periodic acid shift. As we have mentioned, diabetes is BAS positive, while amyloidosis is BAS negative. Only in the glomerulus, no, amyloidosis could be present in the glomeruli, in the tubular interstitium, and in the vessels, and this differs in the clinical presentation of the case. So in the glomerular amyloidosis, it could be more towards proteinuria. Tubular interstitium, it will be more towards affection of the renal functions with the increase in serum creatinine. And amyloidosis is an extracellular fibrillary deposit, not an expansion of the mesangial matrix as in the case of diabetic nephropathy. So amyloidosis is important. Why? Amyloidosis is a serious disease, and it also could be monoclonal. We should put in mind that it could be monoclonal with an underlying malignancy. So let's check the mesangium here. Can anyone say what he can see in this mesangium? اوكي دكتور رامي احنا قافلين الشات، ما حدش هيقدر يتكلم.
ايوه الشات مقفول. ايوه
طيب اقول انا. This mesangium looks expanded, of course, and a little bit fibrillary. So this should raise the suspicion for amyloidosis. This is an H&E stain, so it looks expanded and fibrillary. Here it's more expanded. Let's see BAS stain. This BAS stain, that's the positivity of BAS. If we compared it to this, that's positive, and that's negative, and that's the arteriole with an increase in the thickening of its wall with this deposited material, which turned out to be amyloid. So to this level, this is an BAS negative deposited material. First differential diagnosis for me, it will be again BAS negative. If we compare this with this is pale, so it's BAS negative or weak BAS positive or BAS negative if when compared to this positivity. Okay, let's continue. Amyloidosis, unlike diabetes، احنا قلنا انه extracellular fibrillary deposits. طب الصوت كده احسن يا دكتور رامي؟
تمام اتفضل.
هو معلش انا صوتي تعبان اصلا يعني، فمش عارفه اعلي قوي معلش. طيب الحاجه الثانيه second issue which is very characteristic for amyloidosis is the Congo red positivity. So it is BAS negative and Congo red positive. Congo red positive with an apple green birefringence under polarized light. So that the positivity of Congo red, it will be orange colored, and under polarized light it will give this apple green birefringence. So that's very characteristic, and till this point we have diagnosed amyloidosis. We can diagnose it as amyloidosis, but we have to say which type of amyloidosis. As we have said, it could be an amyloid A or lacto or many other types, but for the commercially available antibodies we have amyloid A and lact, and we should exclude, of course, the monoclonality in these cases with the kappa and lambda light chains. So this case was amyloid A antibody positive by immunohistochemistry, and we can see here the brownish color of positivity in the mesangium and in the glomerular basement membrane as well. With the same if we used kappa or lambda monoclonal antibodies. For another case, not the same case, it will give positivity for the positive monoclonal antibodies with the same color but different antibodies, of course. So we should exclude being a monoclonal disease in the panel of immunohistochemical characterization of amyloidosis. The third differential diagnosis is membranous nephropathy. Why membranous nephropathy could be considered differential diagnosis for diabetic nephropathy? Because it causes a glomerular basement membrane thickening as well, but at this time it is an immune complex mediated disorder. So we'll see immune complexes with immunohistochemistry and under electron microscopy with formation of spikes, spikes that we see in this picture. What are these spikes? Spikes are just an reaction from the glomerular basement membrane that occurs around the deposited subepithelial deposits. So if we compare this of diabetic nephropathy that we have seen above for 2 times, that's the third time with the third differential diagnosis for a smooth thickening of the glomerular basement membrane. But here the thickening is not smooth. We can see these hairy spikes that will be formed on the outer surface of the glomerular basement membrane due to subepithelial deposits, as we have mentioned. So by immunofluorescence or immunohistochemistry, we'll see an immune complex deposits formed of IgG that will be granular that time and C3 granular as well along the glomerular basement membrane. So this is main difference in the between the difference the thickening of the glomerular basement membrane here and in the diabetic nephropathy. Okay, let's continue. I have problem again. Sorry for this interruption. So now we have mentioned a main difference between the glomerular basement membrane thickening of membranous nephropathy, which is an immune complex mediated disease, and versus the glomerular basement membrane thickening of diabetic nephropathy, which is just an increase in the matrix of the membrane and of the mesenchyme. This is a granular for staining for IgG or C3 immune antibodies along the glomerular basement membrane in the case of membranous nephropathy. And that's the electron microscopic picture that reveals subepithelial deposits. These are subepithelial electron dense, and what is meant by electron dense is the black color of the deposits when compared to the matrix of the membrane. And between these deposits are a reaction or new basement membrane material that were formed along the deposits, the foreign deposits that were deposited, and this under light microscope were seen as the spikes, and this explains how these spikes were formed or in cases of membranous nephropathy. The fourth differential diagnosis is light chain deposition disease other than amyloidosis that could be monoclonal. So nodular glomerulosclerosis in this case will mimic diabetic nephropathy in the terms that it will be also BOS positive, but by immunohistochemistry we will see a light chain restriction, a single light chain restriction, either kappa or lambda, or predominance either kappa or lambda. and this is an immunohistochemistry for lambda lighted chain in a case of MIDD or monoclonal immunoglobulin disease that shows positivity along the tubular basement membrane, and this case had nodular glomerulosclerosis in his glomeruli with thickening of the tubular basement membrane that showed this light chain restriction. Under electron microscope in these paraprotein related disorders, we'll see powdery deposits along the inner side of the glomerular basement membrane that are clear here with this higher power or higher magnification in this light chain deposition disease. And let's compare between diabetic nodular glomerulosclerosis and monoclonal immunoglobulin deposition diseases or MIDD in details, because it's critical and they may overlap. Regarding the mesangial morphology, both will show mesangial expansion up to nodular formation with bath positivity and light eosinophilic stain by H&E, even silver stain that is positive in diabetic nodular glomerulosclerosis and negative but could be positive also in MIDD. So let's try to differentiate. The tubular basement membrane. Tubular basement membrane will be thickened and show IFTA or interstitial fibrosis and tubular atrophy with time in both. But in MIDD, it could be more refractile, more ribbon-like thickening in along the tubular basement membrane, and the tubules in the case of MIDD, I think they are very important because sometimes they take the overhand over the glomerular pathology, and they may appear more than the glomerular pathology itself, as this immunohistochemistry that we have seen for a patient is a real case, and the tubular basement membrane took the upper hand because more than the glomerular pathology, and most of the glomeruli in that case showed ischemic glomerular affection more than nodular glomerulosclerosis. So the tubules in MIDD are important. Let's increase the importance of the tubules and say that many cases have a coexisting cast nephropathy with MIDD. And cast nephropathy, of course, is of an underlying monoclonal gammopathies, and MIDD of the same underlying disease. So both are two presentations for a common disease. So it's not uncommon, but it could be common to see them together with and coexist together in the same renal biopsy. Arteriolar hyalinosis in MIDD is non-specific, while in diabetes specific, as we have said. Number of nodules. It tends to be more nodules in a single glomerulus in MIDD, but tends to be more solitary, to see solitary nodule in the same glomerulus in case of diabetic nephropathy. Immunohistochemistry is a definitive diagnosis, the definitive differentiation between both diagnoses. As we have said, diabetic nodular glomerulosclerosis is a non-immune complex mediated disorder, while MIDD is a monoclonal disorder that will show monoclonal restriction by immunohistochemistry. But we should keep in mind that sometimes classic picture, as mentioned under light microscope, may not show monoclonal restriction by immunohistochemistry, and it is classic under light and EM. Why? It could be have an altered antigenicity that were not detected with the commercially available antibodies, and possibly it could be monoclonal but heavy chain and not light chain, because the commercially available antibodies or is usually present in market and most of our labs is a monoclonal light chain for kappa and lambda more than a monoclonal heavy chain antibodies. So this could be the case, and these patients should be investigated properly hematologically to see what is the underlying monoclonal disease, because that's the target. This will be the target therapy to treat the underlying monoclonality or multiple myeloma or any of these paraprotein related disorders. The fourth differential diagnosis is the MPGN or membranoproliferative glomerulonephritis with the mesangial expansion, but this time with hypercellularity, glomerular basement membrane thickening, but with this time with peripheral glomerular basement membrane double contouring, endocapillary hypercellularity that will be evident, and the deposits that will be seen with immunohistochemistry and under the electron microscope. So MPGN could be an immune complex deposition disease. What do I mean by could be? Membranoproliferative glomerulonephritis could be a non-immune complex. Yes, it could be a non-immune complex deposition disease. For nephrologists and for our dear pathologists, a chronic TMA, chronic thrombotic microangiopathy, heals with a picture that mimics MPGN under light microscope, but without immune complexes. But most of the time, or the more common that we encounter, is a membranoproliferative glomerulonephritis that is immune complex mediated. And the most famous is lupus. Lupus nephritis class 3 and 4 is an MPGN pattern of injury that when we put in the context of all lupus clinical picture, it will be named lupus. But for the sake of morphologic description, it's an MPGN pattern of injury, and the first to be excluded in any case of MPGN is the underlying chronic infection. In these cases, granular deposits for IgG and of course C3 will be present. That's a picture of MPGN pattern of injury with the mesangial expansion and a little bit hypercellularity. Glomerular basement membrane here is thick. Let's count the mesangial cells: 1, 2, 3, 4, 5, 6, 7. So it's more than 3 hypercellular, and with the bus stain double contouring, peripheral double contouring of the membrane is more evident, and more hypercellularity here with endocapillary hypercellularity here. Under electron microscope, these are the inflammatory cells, endothelial injury, which is part of the endocapillary proliferation, and these are the immune complexes. Subendothelial, or here is more intramembranous, so not subendothelial. Again, immune complex deposits with new basement membrane formation, so it's entrapped inside the membrane with membrane material here and membrane material here. Here's a mesangial electron dense deposit, another one with new basement membrane material that will end up with double contouring with cellular interposition in between, giving the picture of glomerular basement membrane double contouring and the start of chronicity. So these are the most famous differential diagnoses. Other differential diagnoses are present that may cause glomerular basement membrane thickening. First is dense deposit disease, which could be considered a little bit rare or uncommon, but we often see it, especially in children. Light microscopic picture may resemble MPGN or could be only mesangial proliferation, and may present with a picture of post-infectious GN, acute post-infectious GN with many neutrophils, and by immunohistochemistry we will see C3 dominant deposits with, and by the way, IgG could be positive but with a less intensity. But unfortunately, this picture of the C3 dominant deposit could be just an post-infectious. It does not mean that that's dense deposit disease. Dense deposit disease is a diagnosis of electron microscope. Should be diagnosed only by electron microscope, and we will see in these cases electron dense transformation or change of the normal pictures that we know about the glomerular basement membrane with this electron dense deposited material. So it's a diagnosis of dense deposit disease is a diagnosis of electron microscope. Other differential diagnoses is a fibrillary GN. Fibrillary GN has variable appearances under light microscope and commonly presents with mesangial expansion due to an infiltration with extracellular material, and could be also an MBGM pattern with crescents or even membranous pattern on presentation. And importantly, it's Congo red negative, unlike amyloidosis, which is Congo red positive. Sorry. Deposition is usually polyclonal for IgG and C3 by immunohistochemistry or fluorescence, and by EM haphazardly arranged fibrils with measurement 12 to 24 nanometers, and I have concern about measuring of these fibrils, and I will talk about this next slides. And the most important is the immunohistochemistry of DNA GB9, which is very specific for these cases, and it solves the problem if it's positive. So it's a fibrillary GN. So these are the fibrils that we are talking about, that we have to measure its diameter, not its length, its diameter, which is very hard, except if we have electron microscopes of very good resolutions at very high magnifications. And I think that the differentiation between fibrillary materials, if we are talking about fibrillary disease or fibrillary GN or amyloidosis, which is also fibrillary, other steps may be easier to differentiate than measuring the diameter of these fibrils, I think. But as I said, this is according to the capabilities of your electron microscope, how much its resolution is good. The second is cryoglobulinemic glomerulonephritis, which is also not uncommon, and is caused by intracapillary and capillary wall, often subendothelial and mesangial cryoglobulins, and giving the appearance of membranoproliferative or MBGN pattern of injury. These cases could have purpura and arthralgia due to vasculitis affecting mainly the skin and also the kidney vessels. Abnormal serologic studies, these cases are characterized by low C4 with normal C3, and sometimes C3 is also low. It has 3 types, including both monoclonal and polyclonal varieties. Can cause the cryoglobulinemic GN. The most common is a mixed cryoglobulinemia, which occurs secondary to HCV. And most of the patients with type 2 or 3 cryoglobulins have positive rheumatoid factor in their serum. The cryos are eosinophilic and refractile. They could be termed cryoblugs because they obliterate the capillaries, the glomerular capillaries, and they are strongly pass positive due to the presence of IgM component in these deposits. The acute phase frequently has neutrophils, then monocytes and macrophages, arterioles and small arteries showed what we call leukocytoclastic vasculitis, and sometimes with cryoglobulin deposits as well. Immuno, mainly IgM as we have said, and C3, usually with monoclonal light chain restriction, and their EM will be described with a wormy short fibrillary substructure. Here in this picture we can compare between the normal glomerulus versus this glomerulus was for a patient with HCV. It's a real case with this refractile expansion of the mesangium, and this vessel shows a subendothelial refractile deposit, which proved to be cryos, and these are the cryoblugs, BAS positive plugs occluding these lumen. Under electron microscope, these are the plugs, and these are subendothelial deposits with a higher magnification, these deposits revealed to be of substructure. It's not just homogeneous deposits. They have a substructure, which is what is the description of this substructure? They are thick. They are not thin. If we compare it to fibrillary GN, they are wormy. We can feel that we are looking at worms, but actually these are fibrils. They are of cryoglobulin, substructure of cryoglobulins, and short and haphazardly arranged. They do not have a periodic arrangement. This will be more clear when we compare these cryoglobulin deposits with the immunotactoid glomerulonephritis. These patients have a monoclonal underlying paraprotein disease as well as most of the or two of the types of the cryoglobulins. So both immunotactoid and cryos could be of monoclonals. The difference is the presence of cryoglobulins in the patient's serum. Here is absent, and there was present in cryoglobulin associated or cryoglobulinemic GN. This patient is we importantly know that this patient achieved remission of his glomerular pathology once the therapy is directed against his malignancy. So his malignancy is or his renal disease is related to his malignancy in its progression and in its treatment. So we can diagnose a patient with an underlying malignancy from his renal biopsy that was thought to be any other renal related disorder, not a systemic malignancy. His EM in immunotactoid, let's compare it with the cryoglobulins. It will be well defined, long. Cryoglobulins were short, often parallel, so they have an arrangement, not haphazardly arranged, and no cryoglobulins detected, and they are more IgG, but they're more IgM. So these have parallel arrangement, and they are long fibers, not short as cryoglobulins. Fibronectin, glomerular nodules are both positive, but Congo red negative. It's a deposited fibronectin, which have an immunohistochemical antibody against it, and that was my last differential diagnosis for diabetic nephrosclerosis for today. We should know that diabetic nephropathy is characteristic glomerular, tubular, interstitial, and vascular changes. Its histopathology should be combined with the clinical context, and that's essential. Its differential diagnosis is critical, especially with the nodular glomerulosclerosis. I hope you had the maximum benefit from this lecture, and I'll be happy to answer any questions.
شكرا دكتورة سارة، بجد محاضرة في منتهى الجمال. يعني كانت موضوع الجلوميرولوباثي ده من المواضيع او من المواضيع الصعبة جدا في النيفرولوجي. كان في حاجات كتيرة جدا الواحد كان بيقراها ومش متخيلها. بصراحة الصور اللي انت عملتيها والديفرنشال دايجنوزز والصور والجداول حتى بالصور كانت في منتهى الجمال، ثبتت معلومات في حاجات انا كنت فعلا بقراها ومش متخيلها. بس بعد ما شرحتيها بصراحة انا احييك، بصراحة شرح ممتاز وشرح رائع. المحاضرة جميلة جدا وسلسة، المقارنات حلوة، والمقارنات بالصور حلوة، سواء كانت بالالكترون مايكروسكوبي او الصور الثانيه. بصراحه انا بحييك على المحاضره، فعلا جميله جدا جدا، وبشكرك. الباثولوجي من الله يخليك، الباثولوجي من الساينس الجميله جدا. معظمنا كان بيحبها، او ما كانش كلنا يعني، كان بيحبها في الكليه، كان بيحبها جدا، واللي هي معتمد يعني هي من الساينس المعتمده على الصور، عشان كده هي من الساينس او بيزك ساينس او بيزك ميديسن الجميل جدا، يمكن عكس الفارما او الفسيولوجي كان بيبقى تخيلهم صعب شويه. بشكرك على المحاضرة الجميلة، وبجد حضرتك امتعتينا النهارده في محاضرة رائعة عن الدايابيتك نيفروباثي. أنا دلوقتي هفتح الشات، لو في حد عنده أي سؤال ممكن يكتب في الشات أو يرفع إيده وأنا أخليه يتواصل مع الدكتورة سارة دايما. هو الشات كده اتفتح. لو في حد عنده اي سؤال ممكن يكتب في الشات او يرفع ايده ونعمل له انميوت. هل في حد عنده اي سؤال؟
طيب الحمد لله ما فيش اسئله.
لا ثانية، في حد عنده اي سؤال ممكن يرفع ايده او يكتب في الشات. في دكتورة سلمى بتسأل هو دايابيتك نفروباثي. ثانية واحدة. شكرا. دكتورة سلمى تقول الدايابيتك نفروباثي could be associated or complicated with amyloidosis.
diabetic nephropathy ده ممكن يحصل معاه اي حاجه، لان هو ده disease او يعني complication of diabetes. فال percentage of diabetic patients يعني نعتبره البيز لاين، هو diabetic as a baseline. He could have complicated with post-infectious glomerulonephritis with any other glomerular affection. بس يعني الاميليدوزس بيرسي يعني يعني مش عارف، حظي ده وحش قوي او حظنا احنا مش هنعرف نشخصه.
تمام، شكرا دكتور محمد. لو في برضه حد عايز يتواصل فيربالي مع الدكتورة سارة ممكن يرفع ايده ونعمل له انميوت. شكرا دكتورة سلمى. او ممكن برضه يكتب على الشات. هل في حد عنده اي سؤال تاني على الشات؟ Any more questions? تمام. بجد شكرا دكتورة سارة، المحاضرة كانت جميلة جدا بصراحة. يعني عرض الصور وعرض الكومباريزونز وعرض الديفرنشال دايجنوز كان ممتع. أنا بشكرك بصراحة على المحاضرة وشكرا لوقت حضرتك. كان باين صوت حضرتك تعبان شوية.
يعني صوت
لا بشكرك، شكرا ان حضرتك شرفتينا النهارده. فعلا محاضرة جميلة ووضحت كل حاجة، يعني وضحت حاجات كتيرة قوي في الدايبيتك نفروباثي. شكرا لحضرتك، نورتينا وان شاء الله يبقى في ويبينار كتيره مع حضرتك ليتر اون عن البساطه. شكرا.